Nadeem? Nadeem? Hello? Hello? Nadeem?
Hi Paul, can you hear me?
I can hear you now, my friend. How are you doing? So, are you trying to bring up your picture to show us your glorious features?
I'm not bad, thank you.
Yeah, nice wallpaper.
Thank you.
So Nadeem, I'm going to introduce you to the audience. In the audience we've got a couple of people you may or may not recognise. Over in the corner we've got Saad Niaz, can you see? And in the audience we've got our candidates and an observer. In the back there we've got my friend, he's laughing at us there, just in the air. So he's... And also in the corner is a guy you may know, Wazeem. He's at back there. But we've got Sajda and we've got Vakar Ahmad, who's going to be a recent transfer from Bangor over to Manchester. So,
brilliant.
So what we've got, my friend, I've got your slides up. I'm just going to move your image over here so I can actually see you. We've asked a couple of people if they know anything about colonoscopy, colitis and dye spray. I know we've pre-chatted about making it personal to Pakistan and things, but I'm really grateful that you've been able to take the time out. So I've got your first slide up, which is your introductory slide.
Thank you for giving me...
Hello, Nadeem.
Paul, thank you for giving me this opportunity. And shall I start?
Yeah, if we take the image off, then it'll be a better transmission.
Okay.
So I've got the first slide up. I'll just do the audio. Are you there, Nadeem? Hello? 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 Hello, Nadeem?
Hi.
Hi.
Paul, can you hear me?
I can hear you better now, boss. Right, let me just get your first slide up, my friend. So, my friend, I've got your first slide up. Can you hear us?
I can, yes.
Excellent. So I've got your introductory slide up, my friend. Your title slide is up. If you just say next slide, I'll just move on as accordingly.
Excellent. Thank you very much. So, Dr. Saad, Dr. Vakar and Paul, and I hope all the delegates are enjoying the course. My name is Nadeem Tahami and I'm a consultant gastroenterologist. I would like to sort of share my understanding of colitis surveillance. As you can see on the slide, I'm affiliated with several organizations, including Association for Pakistani Physicians and Surgeons. And I'm also a member of PAGE with our current president, Dr. Saad Niaz, who's directing your course. So next slide, please.
Next slide.
It is usually quite easy to preach the converted, but I will touch upon indications and what is a standardized technique of surveillance and the approach that we adopt in our unit. Can I have a next slide, please?
Next slide.
Now, colonic cancer is third most cancer in United Kingdom. Unfortunately, I do not have access to cancer registry in Pakistan, and I won't be able to quote any data. I will keep it minimum so that I don't bore you and keep it relevant. I am not sure if you've got the updated version of the slide there. When I sent the slides to Paul, I looked at the data and the slides that was at least 5 years ago. Now, from the recent NICE publications, we know that the risk of developing colorectal cancer in patients with inflammatory bowel disease is about 2% after 10 years. And with the passage of time of onset of symptoms or diagnosis, the risk increases. More so in certain risk groups, such as patients with PSC. Can I have the next slide, please?
Next slide.
I'm sure you're all familiar with the different oncogene mutation which leads to colonic cancer. Now, in normal colon, the risk increases in patients who have adenomas. However, that, as you all know, is not true in colitis. And the p53 gene is quite implicated quite early on, which can lead to dysplasia and derangement in the configuration of the colonic mucosa, which can then lead to development of the colon cancer. Next slide, please.
Next slide.
Now, when we survey colon with colitis, the standard approach in the past was to take random biopsies. But over the years, we have moved on to a concept of patient-centered approach, or more so a disease-centered approach when it comes to chronic conditions such as inflammatory bowel disease. So rather than hunting in dark, it is preferable to use chromoendoscopy and then take targeted biopsies. Next slide, please.
Next slide.
So a very simple take-home is that we start surveillance in patients with inflammatory bowel disease 10 years after the onset of symptoms of colitis. This is not true in patients with high-risk groups, such as patients with PSC, where we start the surveillance right from the onset of diagnosis, and we scope them every year. Next slide, please.
Next slide.
Now, we stratify different patient groups into low, intermediate, and high-risk groups. So patients who have extensive disease but quiescent colitis, Crohn's or ulcerative colitis, and patients who have limited left-sided colitis or Crohn's of similar extent, we classify them as a low-risk group. And patients who have extensive colitis with moderate or severe inflammation, either macro or microscopically, and patients with other conditions, PSC, including transplant patients, patients who've had strictures in their colon, and patients with any dysplasia in the last 5 years. Also, the patient with family history are in high risk category. And the in-between category of patients in intermediate risk group. And on the basis of this risk stratification, BSG and NICE have given us a guideline. So next slide, please.
Next slide.
So BSG recommendation is to scope patients who are deemed low risk every 5 years, compared to a high risk group where we scope them every year. Now, biopsy protocol is either to do a pan-colonic dye spraying and then take targeted biopsy from the abnormal area, or people who are starting colonoscopy and starting this practice, they should generally take 2 to 4 random biopsies from every 10 centimeter of the colon. We do have to take into consideration patients' comorbidities, their expectation and their wishes, and also the ease of performing the colonoscopic examination. Next slide, please.
Next slide.
So in the past, we have used methylene blue, but in the last sort of 3-4 years, we've been using indigo carmine. The way our protocol is, we take 10 mils of 1% indigo carmine, that is 1 ampoule. We mix it with 40 mils of water, and we add few drops of simethicone. So we make this solution of 0.2% indigo carmine, about 50 ml solution. We drop in 20 ml syringes. Next slide, please.
Next slide.
And the option then is, we can either use a foot pump or we can use spray catheter. It is incredibly important that patients are adequately sedated. Now, I understand, and with limited experience, I know some units perform colonoscopy under propofol. Now that, I have a slight objection to it, because if in order to change patient position, it becomes slightly difficult, in my opinion. But patients should be adequately sedated. Now, from Buscopan point of view, my usual technique is I normally give 10 milligram of Buscopan when I'm starting the examination. And once I reach cecum and on withdrawal, I give 10 milligram of Buscopan. Now, this is not an evidence-based approach. This is an approach which I have picked up from the expert in the field. On Buscopan, I need to also mention that we recently had an alert out on Buscopan. I'm sure you all understand the anticholinergic effects and risk of causing cardiac problems. So we have sort of limited our use of Buscopan, especially in people with any previous history of ischemic heart disease. Would not perform colitis surveillance in patients with colitis surveillance. It is incredibly important that patients should have a good bowel prep. Use CO2, very helpful, especially for the trainees when they're training, because with the CO2 there's an additional benefit of causing less discomfort, as you all will appreciate. It gets absorbed in the bowel. Next slide, please.
Next slide.
So it should be undertaken by colonoscopists with adequate expertise. Gastroenterologists by nature are people who are known to have less patients. However, this procedure, especially when you're doing dye spray, requires a lot of patience. Now, you've got to give these patients adequate time on your list, so we therefore should not rush it. We usually allocate 3 points for colonic surveillance, colitis surveillance on our list. I do not have any experience of EMR and EST, and it is not next slide, please.
Next slide.
So the technique of performing dye spraying is, as I said earlier, we can either use a spray catheter or we can use foot pump. Now, a good pressure on the syringe. Its communication with your colleague, assistant nurse is very important, so that you can achieve a good jet pressure. And to use jet wash, or you've seen it, you can appreciate when it comes out from the spray catheter. So that do require a good communication. With the foot pump, I prefer spray catheter. I've not used it in the foot pump, but I understand that my colleagues prefer foot pump. So you can mix it with the foot pump solution, and you can just direct the stream to the anti-gravity side of the colon. You will have to keep doing a suction and inflation continuously in order to ensure that once you've injected a lot of solution, you've cleared all the excess dye by suctioning. Next slide, please.
Next slide.
So I'm not sure if this slide comes up very nicely, but if you can see the pictures, you can see this jet wash coming in a spray catheter. Now people understand that it highlights the area, whereas methylene blue just leaves out the of abnormality.
Are you there, Nadeem?
So I hope you can all, yes, I can. So what to look for? So there are three things that you focus on. One is a pattern of normality. You look for depressed areas in the bowel and also comparison is important, and if you train your eye to looking at a normal bowel, you will appreciate what an abnormal mucosa looks like. I'm sure most people will know that the pathology lies in the eyes of a beholder. You need to therefore train your eye. It's not the scope handling which matters. It's also really understanding and getting normal mucosa. There's one more thing which comes, which I would like to mention at this stage, is the communication between you and your assistant and a nurse. Now, I hope Wasim is there in the audience. The reason I mention him is because I have been rescued by my nurses, my assistants, several times in the last sort of 10 years since I've been doing gastroenterology. So you've got to have a very, very good communication and confidence in your nurses. They would have seen hundreds of these procedures, and their eyes probably would be better looking at the normal mucosa. So you need to just change. That would just come with an experience. And once you have a trained eye, then you will be able to appreciate an abnormality from a normal mucosa. Because then a decision comes. So it's not about just scope handling. It's your good hand-eye coordination, and then you're essentially thinking on your feet. You need to make key decisions. So if you come across it, then need to decide is endoscopically or, and that is a very, very important skill to learn. I do not believe anybody can really teach you this. It's just really important is to look at the normal mucosa surrounding that abnormality and always. So if I can have next slide, please. So once you've come across a resectable a lesion which you feel is resectable, please make sure you are able to then biopsy the surrounding normal mucosa. And if it's a lesion that you believe you can resect, but you do not have experience, try not to take biopsy. As many people with a white light and with the chromodox angles, and leave it for experts to deal with. Next slide, please.
45-year-old male. Nadeem? Hello? Hello? No, he's gone. So far what we've seen is that what Nadeem is actually alluding to is that when you spot these lesions, how should you manage them? And he's actually asking you to not resect them if they're beyond your technique and beyond your skill set. I have his slides. So what we'll do, I'll actually continue with his presentation, and So as we can see here from this slide, when that comes up, dye spray comes along and highlights this area here. The examination, this is just to say that it's running or not running. You probably not see on the bottom, but where this actually comes, you can actually see where the lesion starts. It actually starts here and comes down and across here. So what the dye does, it enables you to delineate the margins. Now these, what we say is, if a polyp is over one fold, that is potentially takeable. If it's over two folds, that's one fold too far. So over one fold, it's takeable for somebody with the experience. For somebody without the experience, it is one fold too far. But regardless, two folds is something that Saad and myself would be exceedingly reluctant to take on. Nadeem?
Hello.
Hello, my friend.
Yes.
So we lost signal there. I've just taken, just discussed with them the slide that you've got for 45-year-old male about highlighting and delineating the margins, and I've just progressed it onto the 55-year-old male with UC and 20 years, no family history.
Pattern, comparing it with the normal mucosa surrounding it, and always making sure that you take the biopsies on the surrounding mucosa as well. So can you show them the slide from start to expert, please?
So which slide is that? Is that the 55-year-old male? Start to expert?
So moving on from start to expert.
Yeah, I've got start to expert. Yes?
So, starting off, it's recommended that you should just take biopsies from every 10 centimeter of the bowel. And with the passage of time, I would just advocate using the dye spraying and but just continuing with the taking biopsies from every 10 centimeter. After a while, once you have mastered the skill, then if you move on to taking targeted biopsies, that would be perfectly acceptable. There are lots of videos online available, and you can find lots of information, videos on social media as well. And there are books available as well, which I can always recommend if people are interested in reading. It is important to take time to examine and sample anything that you come across which is unusual. But it's a key decision making. You do not want to make a life difficult for a second endoscopist, colonoscopist who will embark on a journey of doing an EMR and ESD. So you have to be quite careful what you're biopsying. So a good description, a good reporting, and taking pictures is also important. So you have to take into consideration your macroscopic finding with microscopic finding. And at times you have to rely a decision purely on the macroscopic finding. So next slide, please.
Yes, my friend, further reading.
So I'm nearly at the end of my presentation now. Paul will hand out my slides so that you can go into this nice guidance which was issued not in a distant past, and you can look through it. It is a very useful document to read, and it will help you in planning your approach in developing an approach for colitis surveillance. So that's all I have to say. If I can have the last slide, please.
Last slide.
Please.
Thank you very much, Nadeem. Anybody got any questions?
Very much.
Any questions?
So,
So Nadeem, I've actually won. We asked our previous speaker about large flat polyps and biopsying. What's your opinion if the endoscopist who sees a large flat polyp about taking biopsies from it?
So I personally feel, now as I said earlier, I am not an advanced colonoscopist. I do not perform EMR and ESD. I mainly rely and make decisions based on macroscopic appearance of the polyp. If you have a good white light endoscopy and if you have a trained eye, in most situations you are able to base a diagnosis. Biopsying a normal mucosa surrounding a flat polyp is important, but I would personally not biopsy it. I will have a good look at it. I will look for any areas of significant abnormality, take as many pictures as possible, and be as clear in my report as possible. If you have an expert scope next door, there's no there's no harm in taking a second opinion at that time.
Thank you very much. Anybody like to ask any questions? This is a man who's taken a lot of time out to put this together for you. Anything? Saad?
How long does it take? I mean, how much?
Saad's got a question for you, my friend.
How much more time does it take to do this colonoscopy? And do you give extra in your slot? Does that have extra time?
So in your presentation, yes, Nadeem, you actually said 3 points. Would you like to explain that?
That's correct. So our lists are usually, we have a 12-point list, i.e. a standard colonoscopy is 2 points and an endoscopy is 1, OGD gastroscopy is 1 point, diagnostic. So we usually have 12 points on a standard list. But if we have, so we have dedicated lists for surveillance, colitis surveillance, and on those lists, we usually have maximum of 4 colonoscopies. So i.e. each colonoscopy is given 3 points and we have maximum of 4 procedures. It takes a lot of time, and obviously with experts like Dr. Vakar and Dr. Niaz and Paul, you wouldn't probably take much time, but people who are early on their training will have to spend a lot of time. It can easily take up to 45 minutes to an hour in order to give a good and adequate, do an adequate examination and produce a report.
Just one more question.
Please.
I see in Pakistan, I see a lot of patients with colitis who have not had their 10-year disease, but who will regularly have colonoscopies just to assess their severity, progress. Is that something you ever see in UK?
So there are patients who will have grumbling symptoms of colitis, however, will not have significant inflammation in their bowel, and there are also symptoms who will have macroscopically and microscopically moderate to severe inflammation, yet they will not have many symptoms. So I personally do not believe there is a direct and established correlation between mucosal findings and the symptom severity. I do not advocate, and I think it's not DSG, and I'm sure Paul will second it, that DSG does not recommend this approach.
It doesn't.
Thank you.
There's a lot of people, Nadeem, it seems to be that suddenly they'll say, 6 months ago you had colitis, we've diagnosed colitis, your symptoms have seemed to not settle down, let's have another look. Now, in that group, I think that's unethical. I think that just means that your treatment plan isn't as effective, and therefore you need to look at your treatment regime. What's your opinion, my friend?
110% I agree with your statement, Paul. That is absolutely correct. I think it's the treatment escalation which needs to be looked at rather than looking at disease severity. Unless a patient is having an acute flare-up of colitis, where you may want to do a limited examination, unprepped examination, and maybe just taking biopsies to exclude things like CMV colitis or maybe any superimposed infections. But no, I would agree with you entirely that it is not indicated.
Okay, the reason why I asked Nadeem this question is because I see this all the time in Pakistan. Patients with ulcerative colitis, I've seen them having colonoscopy every year just to see. And the reason given to them is we just want to keep an eye on things. So that's why I asked, which is obviously, as you rightly said, it's nonsense. There are very clear indications on who should be scoped again, if at all, who's already diagnosed colitis and you know everything about them. Of course, surveillance is different. What Nadeem was talking about was people who had colitis for 10 years, and then you divide them into these 3 categories and then decide whether you're going to colonoscope them every 5 years, every year or every 3 years. But to do colonoscopy in patients with colitis just because they've had a flare-up, who are known to have colitis, is absolute, I think
I think it's unethical.
Absolutely. Absolutely. So I think this highlights 2 important points here. Now, one is the medication, and obviously a patient will have more confidence if they are well, if you educate them well and give the evidence. And secondly, obviously, it also entirely depends on the expertise of a gastroenterologist, because if you are seeing somebody who has clear display credibility in that area, then I'm sure patients would sort of listen to them more. So it's the communication with the patient and developing your credibility is incredibly important.
Excellent, my friend. I'd like to thank you for taking the time, Nadeem. I think that's a nice thought-provoking discussion because it brought up a lot of topics. One about dealing with colitis, two, one way of actually surveying colitis, and a cost-effective way. So really, just one question is, how much do you think it costs financially for the actual dye spray?
Now you've got me there. I don't know the answer.
It's actually only about £5. So £5 in the UK is not a lot of money.
Exactly. So as I said, it's a cost-effective way, but I cannot answer. I mean, you've answered your question yourself. Thank you. I don't know the answer.
Yeah. So what we're saying is to increase your ability, pickup rate for these type of flat lesions that we know that can occur in chronic long-term surveillance patients. If you just took a little bit more time, and your technique is absolutely superb, that would suit this, and then just do a little bit of dye spray, you would then have increased your chance at picking up these lesions that could. It's a cost-effective way, but time costs you money in Pakistan. That's the thing. Are you willing, as clinicians in Pakistan, to spend the time, but make sure that your integrity of saying, I have made sure to the best of my ability, to the best of the tools available to me at this time, that your bowel is as clear from risk as I can do for you today. And this technique that Nadeem's talked about is a very good technique if you want to study it and learn it, but it takes time. Time means money to you guys because it means you're doing less procedures. No, what Nadeem was actually saying, it's not the inflamed mucosa. You're surveying a known colitic patient. There may be quiescent colitis. There may be some scarring. He's saying you spray the entire colon. You deflate the colon once you've put the spray in. That's to coat it. You then slowly inflate. You take away some of the residue and you look for any islands that are highlighted. He's also asked me, is that correct, Nadeem, that I can share this presentation of yours?
Absolutely, absolutely.
So
yes,
he's got some references for you to refer to. But the thing is, if you're going to do it properly. It's those people who don't do it properly that give things the bad name. So just because you dye spray doesn't take you 5 minutes, it takes a lot longer. Okay.
Absolutely.
Any questions?
Thank you very much, Paul.
Thank you very much, Nadeem.
Sorry, I've got
much appreciated. I'll catch up with you when I get back. Thank you. Bye.
Brilliant. Thank you. Bye.
It doesn't actually cost you. It doesn't cost you a lot to get methylene blue or individual here either. In fact, it's much cheaper to do that. You can use standard. If you don't have the spray catheter, you can also use the standard catheter. I don't think there should be a big issue with that. It's basically just pouring this solution, lining the colon with it, and then just looking at areas that might become more visible after you've done this, and then attacking those areas and taking it from there.
So, do we start dyeing the mucosa from the cecum and come back by connecting?
I think the main problem here is not the material cost, it is the time.
Yeah.
Constraint, and that's one of the major reasons why most of the universities are not taking it on because of the time restraints. It is quite a tedious process. You have to be dedicated to do it and move forward.
Callie's running a couple of minutes late, so it's not a problem. Hopefully the two presentations